Good evening, everyone. On behalf of the Saudi Patient Safety Center, I would like to welcome you all in our webinar for today with the title, Utilizing Data and the Role of Measurement in Patient Safety. My name is Dr. Rakan Al-Mughir. I am a Senior Patient Safety Specialist at the Saudi Patient Safety Center. I will be moderating this session for today. So it's my honor to introduce Mr. Faisal Al-Wataibi, our speaker for today. Mr. Faisal is a patient safety specialist at the Saudi Patient Safety Center. He has a bachelor degree in biomedical technology from King Saud University. Also, he has a master in quality and patient safety improvement from the University of Nottingham in UK. Also, he's a certified professional in healthcare quality, CPHQ, from National Association for Healthcare Quality, and a certified KPI professional from the KPI Institute. Please join me in welcoming Mr. Faisal to walk us through this very interesting topic. But before we start and give the mic to Mr. Faisal, we are happy to receive your questions in the Q&A section, and we will answer them all at the end of the session. Mr. Faisal, the mic is yours.
Bismillah ar-Rahman ar-Rahim. Good evening. Thank you, Dr. Rakan, for the introduction. First, I'd like to take the opportunity and thank the Saudi Patient Safety Center to give me this chance to participate in the webinar series. So in today's webinar, we will speak about utilizing data and the role of measurement in patient safety. So our main theme is to focus on how we use the data and measurement in order to improve the patient safety. During the coming 40 to 45 minutes, we will speak about some important topic about measurement and improvement of patient safety, starting with explaining the purpose and the role of measurement of improving patient safety and how measurement and data contribute to the revolution that happened in the patient safety field. We will present some method and methodology and models and approaches that can use data for improving performance related to patient safety. We're going to list the step of developing indicator, the patient safety indicator. We'll discuss briefly about different way of monitoring the data related to the patient's harm. Also identify the best practice for measuring patient safety and the recommendation. I prefer to start back in the 90s, where the Institute of Medicine has released the landmark report in 1990, to error is a human. This report has changed the way of thinking about patient safety and how we think about medical error. And one of the contribute for this impact of this report during the previous 20 years was because of the number and the data that present in this report. Among these data and the number, the report has shown that around 44,000 to 98,000 Americans die every year because of medical error. The same when he speak about the cost of the healthcare system. So around 17 to 29 billion dollars. That is the cost of the preventable adverse event due to the increase of hospitalization and all the medication that will be provided to the patient. When we think about the medical error, one of its type, it's the medication error. And also the report has stated that around 7,000 Americans die every year because of medication error. You cannot influence all of the people unless you provide them with some fact and number. And this is the role of the data and the measurement. And this is the Institute of Medicine what used to influence in the decision maker of the healthcare system in order to make or to grab attention for the patient safety and medical error and design the new healthcare system with a safer practice. 2 years after this report, the Institute of Medicine in 2001 released another remarkable report, which is Crossing the Quality Chasm. They speak or they shape the new health system for the current century by stating 6 aims for quality improvement. The care that we should provide it to the patient, it should be safe, which means avoid the harm to the patient from the care that we provide to them. So one of the quality improvement aim to provide safe care, also to provide timely care. That means we reduce wait and sometimes the harmful delay. Also, we try to provide an effective care, which means provide service based on evidence-based and guideline, to provide efficient care, which means avoid waste in terms of equipment, supplies, effort. Also, our care should be equitable, which means there is no discrimination in regard to the gender or ethnicity, nationality, etc. Also, our care should be patient-centered. We should provide care to our patient with respect, and we keep the individual in the mid of the health system. And all the improvement effort should be aiming to meet the patient need and expectation. And as we can see here from the 6 aim, safety is one of the quality improvement aim. So patient safety and avoiding harm is sub aim from the quality improvement aim. And this is our focus in today's webinar. Now we speak about the quality and the improvement and how to think about the patient safety and the report that released about patient safety. Now the question is, why do we measure? Why we have measurement? Scientifically, there is 3 reasons to use the measurement in healthcare. First is the research, second is accountability, and third is improvement. The research is aimed to test some hypotheses, and the outcome is to approve or disapprove this hypothesis. So basically, you might focus in some cases in some population to try to test your own hypothesis. Accountability has maybe some negative understanding, but what we mean here, when we hold people accountable by using the measurement, we just need to tell them that your service, which you are accountable for, need to function in a better way or in better level. That's the main accountability in the use of measurement. Our focus today is use the measurement for improvement in healthcare and more specifically in patient safety. So how we can use, or what's the benefit from using measurement for improvement? The measurement, it can tell us how well our current process is performing. So if you ask yourself or ask your colleague in the organization how we are performing in relates to patient safety, any answer that you get it without using a number, it's just opinion. This is not my word, it's Edward Deming word. He say, without data, you are just another person with opinion. So if you want to prove how is your performance is doing, you have to prove it with a number, with the result, with monitoring the performance, with using the measurement and reliable data. Also, not only to have an idea about how we are performing, also if we have aim in terms of the organizational wide aim strategic goals, or you have a short aim for current project, the measurement help you to answer the question if you have reached to your aim or you haven't. Also, if you have a variation in your process and you want to control it, you cannot control anything without measuring first. So there is a famous quote, if you cannot measure it, you cannot improve it. So you start with a measurement in order to make any improvement effort. Also, one of the golden rule in terms of quality and patient safety improvement, never go and implement your improvement in general or large scale. You should try to test the change that you want to try to make, which you will see later if it's result in improvement or not. So what can tell you if this test is resulting in improvement or not? It's the measurement. So based on the result that you get, you can decide if this test, the change that you try to make is resulting in improvement or not. Also, if you sense or recognize the improvement from the intervention or the change that you have already made, you might to see if our improvement is sustained or not by keep monitoring the data related to this improvement project. So whenever you are using the improvement methodology or models, you will find the measurement is essential part in any improvement project. Before we dive deep in the improvement models and approaches, let's speak about the healthcare system and the outcome. Assessing and improving outcome required understanding of the system and its element. So it's not only about what happened between the patient and the healthcare provider. This is the outcome the patient will get. It always depends on the factor and the element in the system, such as the structure. We mean by the structure is our staff. Do we have adequate number of staff? Do we have the supply needed? Do we have, what about the skills and the knowledge of our staff? The process that we have in place, do we follow the guideline? Do we adhere to standard? Also, culture is highly important because culture is the value and the belief that we have it in the organization, which shape our practice. So it's really worth looking in this factor or the element of the system before you decide to improve the outcome. Sometimes you need to focus on one of them in order to get a better outcome. When we think about the system and how to assess it or measure it, it's worth mentioning the Dunabedian model, where he divides the system or categorize the system into three parts: structure and process and outcome. The structure refers to the attribute of setting in which care occurs. And if you want to assess the structure of the system, you might develop a structure measurement. An example of that is the availability of emergency medication, because if you don't have it, that will reflect for sure in the outcome that will deliver to our patient. Also, the staff to patient ratio, if you are measuring it and you are not doing great in this measure, for sure you will find a shortage, you will not provide the care that expected to be provided. So structure is highly important to be measured. The second one is a process, referred to what is actually done. What is the steps of the system before we reach to the outcome of the healthcare profession? So it's worth looking into the steps because as I can see it, the structure is shaping our process and process is reflecting on the outcome. So it's worth to look into the outcome and assess and measure the outcome, and also measure the process which will reflect on the outcome, and measure the structure as well. The third one is the outcome, referred to the effect of care on the health status of patient. An example of that in the patient safety context is surgical site infection, a patient fall, pressure ulcer, any kind of infection, or maybe medication adverse event. These are examples of outcome measure related to patient safety. What is really common and how we usually measure patient safety, we measure the performance related to patient safety by monitoring a certain number of indicators. As I mentioned, patient fall, pressure ulcer can be example of this. One of the common tool and valid tool to be used, and I recommend it to use it in the hospital, is the patient safety indicator, which was developed by the AHRQ, Agency for Healthcare Research and Quality. They have COMS measure patient safety indicator 90. Also, the IHI global trigger tools, it helped us in our performance and see how the process is being carried on, and is there any harm reached to our patient. Also, we can monitor the patient safety from counting the frequency of the incidence of harm by using the incident reporting system if we have it in our organization. And as I mentioned previously, culture is highly important and it shapes the practice. So the value and the belief, it would really, if you are valuing the patient safety, you will do or adhere or comply to a standard, you will follow the policy. So it's highly important to measure the patient safety culture. And one of the famous tools, it was developed by the AHRQ, which is Hospital Survey and Patient Safety Culture. So speaking about the improvement, let's take one of the most common model used for improvement, which is the IHI model of improvement. Basically, when you have any issue related to patient safety or other, you might to think about to adopt one of the quality approaches or model. And here specifically, let's consider that we have an issue with the patient safety. For example, we recognize that a lot of patient fall incident that we report through the incident reporting system. And the model of improvement is consists of 3 questions and PDSA cycle. So the first question you're asking yourself, what are we trying to achieve? What's the issue? What's the problem that we have? And what influence we would like to make in the result of this process. So the first question is you ask what is the problem and what we want to achieve in this project. The second question is how we will know if we are making a change in the process, how we will know if this will result in improvement or not. And here is what I mentioned previously is the essential part of any improvement project. You will find the measurement is essential part. So how we will know if the change is improvement, here is where you need to choose and develop the right indicator which can help you to answer this question. The third question, what kind of change would you like to make in order to achieve your goal and to tackle this problem? As soon as you answer for all these questions, you have to go for the PDCA cycle. And one of the golden rule in improvement, you should pilot the test or the change before you implement it on the large scale. So the first scale usually, or cycle, sorry, it can be for testing. So the first phase of the cycle is a plan. And before you plan the implementation, how you're going to implement it, who's going to implement it, also consider planning for the data collection that will be used to measure the progress of your project. So you should probably plan for your data collection, how it's going to report it, how often, and based on this, you will start to execute your plan either in the implementation of the change or in collecting data. So in the second phase, we will do the plan by making the change or testing the change. In the study, here is where relying on the measurement and the data. We have to review the data. Is it as what we are predicting or is it different? So we assume that if we make this kind of change or the safety bundle in this area, it will result in improvement to that level. So after a couple of months, for example, you might need to review the data and see the measurement if it's telling you what you are expecting, or you need to change the intervention that you try to implement. Based on the decision that you take, you start to act and then plan for another cycle. Here is just to give you an example from the model of improvement and how is essential the role of measurement. Let's look at another example of the model, which will now in quality improvement. But here we are seeing the quality improvement project from a measurement lens. Quality measurement journey is a model, I would say, it's developed by Robert Lloyd. He assumed that the measurement is a journey during the quality improvement project. It goes through a couple of milestones, starting from the aim, then concept, then measures, then we define the measure by operational definition, then we plan for the data collection, then we do the data collection and the analysis, then we will act, which is the part of the quality or patient safety improvement. Let's elaborate in each milestone. So the first one is the aim, which is the first milestone in our journey, which required clarity about the aim of the measurement. So in this model, we are focusing about the measurement, but we should ask the question why we are doing this measurement. To which of the project related to this measurement? It's not only the project. We think about the hospital mission and strategic goal. For example, if you have one of your strategic objective is to improve the surgical outcome or reduce harm, which is widely used in healthcare. We keen on providing safe care to our patient, which can emerge from this strategic goal, a lot of strategic objectives. such as improving surgical care and reducing harm. However, this objective is not measurable. So it needs intermediate step or another milestone to make it into a measurable objective. So the second step is, or the second milestone is the concept in the journey. So it's intermediate step that will help the team to set the boundary for measurement and data collection. And for example, considering the reducing harm is our aim in the measurement journey, we can emerge from this aim various number of concepts. For example, reducing patient fall, it will help us achieve the strategic aim or the strategic objective, which is reducing the harm. So reducing patient fall, if we're gonna assess it, we can develop indicator related to the concept. But reducing the harm, it's quite broad, so it's hard to be measured. So aim is not easy way to measure. It's some generic, I would say, goal. You don't have to measure it. You have to develop a very detailed objective in order to measure it. Also, another example or concept can be used to achieve the aim of reducing harm is reducing medication of adverse event. If you assure that you have achieved your goal in reducing medication adverse event, for sure you're gonna achieve reducing harm, or you will impact at least in reducing the harm on the organizational level. So how we can link the measurement or the measures or the indicator with the concept and the aim? Here we present a tool which will now in the quality improvement. It's a driver diagram where we link the aim to the concept and the measures. Basically, driver diagram, it's you just have to draw your aim or goal that you want to achieve it, and then what kind of primary driver that we have in place that can reflect and help us in achieving this aim. So we can consider the primary driver is the concept. For example, here we have aim, improve surgical outcome. Our primary driver to achieve the surgical outcome or to improve the surgical outcome is by avoiding mistake. This is a concept. Also, avoiding complication. This is a concept. From this concept, you can get more than one indicator. For example, avoid mistake, we can measure the retained foreign object inside the patient body. We can measure how many wrong case do we have, wrong surgery, sorry, how many wrong site surgery we have, how many time we correct patient mistakenly. So these kind of mistake that we should avoid it in order to improve the surgical outcome. Another concept is avoiding complication, such as surgical side infection, VTE. All these complication will impact on the surgical outcome. So you can, again, develop an indicator or select indicator to measure these concepts, such as the rate of surgical site infection and VTA rate also. The secondary driver, think about it as the intervention. So how are you gonna decrease the surgical site infection? For example, by implementing surgical safety bundle or VTE bundle. This is intervention. So secondary driver usually is intervention. Primary driver is the concept and the aim, what is our ultimate goal. When you are measuring the intervention, actually you are measuring a process. So you are measuring the step until we reach to the objective, which is the concept. And if you are keep measuring couple of concepts, you will be assured that you will aim be achieved. So we select or develop an indicator by using the driver diagram. The fourth milestone in the quality measurement journey is to define your measure and indicator by using operational definition. It's basically, it's a form. Most of the hospital have it, sometimes called KPI card, KPI agreement, KPI operational definition. What's benefit from this form? Actually, it gives you a clear idea about the meaning of this indicator. If you are working in an improvement project to reduce eclampsia, for example, or to reduce surgical site infection, or any kind of harm that might reach to our patient, everyone in the team that should know what we mean by surgical site infection. What is the calculation formula? What is included? What is excluded? So operational definition is to provide us a clear an ambiguous meaning. It specifies the measurement method. Do we use log sheet? We will rely on the electronic system. There is someone should be measuring it or reporting its data. So it's to provide also decision-making criteria when necessary. For example, if you draw your baseline or you have baseline based on this, you start your own improvement project, and you think there is a need to enhance and improve the performance related to this. But how we can start this improvement project and we think we have succeeded? You should have a target. Based on the target, later when you present the data of this measurement, you will decide if you have achieved the goal of this improvement project or not. So measurement and the definition, it should specify the target that you want to achieve, which help us in the decision making. Also, if we elaborate more in the data collection process, it will enable the consistency of data collection. So there is certain element you should include it when you are developing any indicator or try to develop a form for a hospital to develop indicator later. The essential element is the name of the indicator, the definition. You should write the detail. What do we mean by this indicator or measure? The formula, the numerator, denominator, also the inclusion criteria, exclusion criteria, the target, the threshold, the sample, the data collection method, and for example, the data collection custodian, who's gonna report the data, who's gonna collect them, the frequency, how often these data will be reported. And for example, if you want to think about the inclusion, brushal ulcer, one of the most common used patient safety indicator. So maybe each institution has their own inclusion and exclusion criteria, but the most common one is they include every brushal ulcer stage 2 and above. You might find in some institution they use different inclusion and exclusion criteria. Here is just to make it clear idea. I've just made it up to show you how the operational definition form look like. So basically, you try to identify the owner. Here is the accountability part that we speak about it earlier. And what kind of strategic goal, which is the aim, we try to link it with the aim that we have it in the organization. We try to put the indicator title or the name, the definition, the formula, inclusion and exclusion criteria. Do we have to use sampling or we will go for 100% of the population? Data collection facilitator, coordinator, custodian, who's going to report the data or collect them? You should give the responsibility to someone because otherwise you will can't ensure the consistency of the data collection. Also the frequency, how often, is it monthly, is it quarterly, biannually or annually? The target or the benchmark, you might go back to the literature and the evidence base and see what is the benchmark for this indicator. Again, when you are working in improvement, you should have more than one target. So if you are doing bad and you are not satisfied with the result in the start of the project or the baseline data, you might set for yourself a realistic target for the coming period. For example, by the end of this year, we will decrease this result by 2%. However, we haven't reached to the benchmark, but the benchmark, we were gonna reach it hopefully after 1 or 2 years. So it's worth considering the realistic when you setting your target. Also, threshold should be used. So what is acceptable range, what is not acceptable range, and what is the range where there is it's not acceptable, unacceptable, it's need more improvement, but we can accept it. Also, you have to get agreement between the team, at least the process owner and the patient safety officer or the quality department. So you assure that a definition is agreed between all the stakeholders. The fifth milestone is to plan for the data collection. And when you think about to plan for the data collection, you should consider these questions, and by answering them, it will be easier to you to make your plan for the data collection. So basically, you're gonna ask how often we're gonna report the data or collect the data. So here we speak about the frequency, as I mentioned, monthly, quarterly, and how long is the duration that we're gonna collect the data? Is it for specific improvement project, or this indicator or measure is supposed to be one of the KPI for the department or for the whole organization? We should keep monitoring it over time. So for how long you're gonna collect the data for this indicator? Is it until you finish this improvement project, or for ever? Will we use the sampling? Again, the sampling, it depends on the population and how large is it. If you use the sampling, how you choose it. How we will collect the data is by using a specific log sheet or data collection sheet, or we will do a survey. We rely on electronic system, incident reporting system. So what is your source of data? Again, the fourth questions is who will go out and collect the data? And here is we mean by the data collection coordinator. So as you can see, you can do both the fourth milestone and the fifth milestone together, because a question that you will answer to develop your plan for the data collection, it will help you to fill the operational definition form. Again, you ask yourself, do we have already have a baseline for the data, or just we measure it because we realize that we have a problem and we don't have indicator? This is just recently developed indicator. The seventh question is, do we have a target? Again, it could be more than one target for the short period, and a benchmark, how the data is going to be validated. You should assure the accuracy and the reliability of the data. So the sixth milestone is the data collection. So basically here you execute your plan, and it's good to consider the reliability and the validity of data. Reliability refers to the consistency of the measure, whether the result can be produced under same condition. Validity refers to the accuracy of measure, whether the result really do represent what they are supposed to measure. So the seventh milestone is the analysis. So after collecting data, you are now having a raw data. It doesn't tell you anything. These data need to be turned into information, a meaningful information, where the decision maker and the stakeholder can take action based on them. So on this stage, you try to use some graphics and analyzing tool in order to turn this raw data into information. Also, you try sometime to compare the performance to the baseline before the implementation of this project, or to decide how far are you from the benchmark. Also, you use the analysis to look for pattern or trend. Try to understand the variation of the process. If you have one and you are targeting to control the variation within the process, there is a lot of analyzing tools, but among them is the Runchart, control chart, histogram. And these are the one that we're going to elaborate more, but there is a huge number of analyzing tools and graph and chart which help you in analyzing your data. The Runchart is a graphic displays to study and observe the process performance for trend or pattern. The benefit is when we decided to use the Runchart, it to detect the trend and the shift in the performance. So as you can see here, the first data point, we have a median with almost 2.7, and our aim is to reduce this result to lower level. So after the implementation here, we have the median has changed to be around 1. So you can sense the pattern has changed, and you can also recognize the improvement. Another tool using for analyzing data is the control chart. It's a graphic display of process performance variation over time. So when you are using control chart, you are aiming to keep monitoring and controlling the process variation. Also, it's quite important to distinguish between special and common causes. So, for example, for these two data points, the data point has throughout the control limit. So, what is the difference between the run chart and the run chart and the control chart? In the run control chart, we have upper limit and lower control limit. The data outside the control limit, it's considered as a special cause, which should stop you and think and investigate more why this is happening. But if the data inside the control limit, that consider common cause. So it's part of the process. Histogram is another way of analyzing data. It's a type of bar chart that display the frequency of occurrence of continuous data and will aid to or in analyzing the data. As we can see on the right side, this is an NHS report has released in the previous week. So they try to show the NHS most serious and avoidable error. They divided or they display different kind of error and how is the frequency different between the type of error. So as we can see here, the surgery performed on the wrong part of the body and foreign objective is crucial issue in the NHS and the UK. So if they want to take a decision or to take an action, this display of the data or the analysis of the data help them to identify where the data or where the area they need to allocate their effort. Before we finish an analysis, it's worth to talk about benchmark. So you might heard me say it during this presentation, or you might came across this word while you're working in a improvement project. Benchmark, it's defined as a process of measuring product or service or process against those who will now as to be role model in one or more aspect in their operation. So there is a couple of steps. So basically, if you are in hospital X and you're thinking that you are not doing good in one of the patient safety indicator, for example, CLABSI or the VTE rate or surgical site infection, you would like to see what is the benchmark, what is the ideal level of performance. So you try to find a hospital that has provided the same service with the same bed capacity. Before we dive deep into the steps of benchmark, so just to give you the idea of benchmark. So you want to reach to that level of the organization, for example, why you want to reach with your performance to their level because you know them as a role model in the field. So the first step is to define the scope of benchmark. So if our focus is the CLABSI, so we will take the CLABSI only and benchmark it with the hospital Y. Study your own process. Before you go out and benchmark with anyone, you have to study the process. You have to look for the root cause of your problem. You try to identify partner organizations, which is the benchmark organization. So you try to look who is doing better or known as a role model in the field and specifically in the scope of your benchmark. Try to approach them. Sometimes they can share with you their data, their way of practice, which might help you in your project. Once you agree on collecting data from them, you can compare the collected data, the result, and the difference between your practice and their practice. Once you have the difference between their practice and your practice, and you analyze the gap in the result between your performance and their performance by using the measurement and the data, you can start to develop your action plan and make change in your practice in order to reach to the benchmark. So just to recap the quality measurement journey, the first aim, for example, if you would like to focus on the organization aim and objective, the concept is how we're gonna achieve the organization objective by making a measurable objective for a specific project. Measure is the indicator. So basically here you try to select the right measure or develop them if you haven't. Operational definition, you try to define in very details what do you mean by this indicator. Also the data collection plan, you make plan for your data collection process. Analysis is where you turn your raw data into useful, meaningful information that will help in taking action. When you present your data to stakeholder, it might be quality council chairman, patient safety committee, you try to think about it as a presenting a story. What kind of story you would like to present? So what is the story? What is the scope? Is it about the ulcer? Is it about the infection? Is it about the compliance to standard? And who is your stakeholder? Who is gonna take the decision or make an action? Is it the medical director? Is it chairman of one of your committee in the hospital? And how you are gonna present it? You are going to present it compared to the benchmark. You are going to compare it with your previous performance to show him there is a deterioration in our performance. So just these questions to be considered when you are presenting your data to take action or to make any decision. Before we move from the quality measurement journey, the steps from this model is in developing an indicator is to select the right indicator, to define them by using operational definition, to do the data collection plan, and to analyze the data and to take action based on the results. Speaking about performance and indicator, we would like just to give you an idea what is the best practice and the well-known organization recommended to be used in order to monitor and measure patient safety. So AHRQ, Agency for Healthcare Research and Quality, they have a tool, the Patient Safety Indicator 90. It's actually a set of indicators to provide information on the potential complications and adverse events in the hospital. They were about, I think, 21, and they reduced to be around 10. They are pressure ulcer, we can have fall, hemorrhage, acute kidney injury, unrecognized accidental puncture, respiratory failure, post-operative sepsis rate. These are the PSI components. It's recommended to be used in the hospital to assure that you have information and how you are performing related to the patient safety and react based on the result of this indicator. Also, another useful way to measure the patient safety is by counting the frequency of the incidence of harm. So incident reporting system is a useful tools and resource of data. Incident learning and reporting system is built to be a voluntary system that will allow staff to report patient safety event, to do further investigation, learning from each single incident, and try to put a safeguard and measure in place in order to prevent the reoccurrence of such event. However, if you try to not to think about each incident separately, you would like to focus on the aggregated data, you might get a piece of information that's useful to start to work on improving patient safety. For example, you might, by analyzing the aggregated data, you might come up with comparison for the incident type and the number over the period. For example, you might find there is a medication administration error. It happened at the end of the year where the people is taking their holidays, and which cause shortage in staff. So it might get you some information that is actually help you in improving the patient safety. It also identify a trend. So if you compare one area in your hospital to other in one of the type of the measure, it also you will come with information and idea to see if this department is not complying to the policy and they didn't comply to the safeguard that we put it in the process in order to avoid the recurrence of such event. Here we can see this chart. It's called Parity Chart, where we use to analyze an incident reporting system data. As we can see here, we have a medication error. It happened, let's say, for over a year, which is around 430. And as you can see, if you which kind of error, medication error happened, here we have the dose missed, the wrong time, wrong drug, overdose, etc. So out of the 430, 92 of the incident was caused because of the dose missed, and 83 was causing 83 out of the 430. So instead of focusing to reduce all of kind of medication error, there is something called Parity Chart, which is focused on only 20% of the causes, which should impact on the 80% of the result. So basically, you draw the causes on the horizontal line and the frequency on the left side on the vertical line and the percentage on the right side. And your cutoff point actually is the 80%. So you came across this one and you add the cumulative. For example, here we have the 20% out of the 430. If you add the 83 to the 92, you will get around 40% out of the 43. And if you add the wrong drug, you will get around 55% of this 43 medication error happened because of these three causes. If you add the fourth thing, you will reach to the 80%. And these are the causes where you should allocate your effort to save your time and effort, which will result in a huge improvement in reducing the medication error. So it's simple concept in using Parity Chart, focus on the few vital rather than the trivial many. Again, 20% of the causes result in 80% of the result or the outcome. So here is to just show you how we can get an information if we use the aggregated data that we have it in our incident reporting system. Speaking about the performance of patient safety, the IHI has developed a tool called Global Trigger Tools. It's a methodology to use retrospective review of random sample of inpatient hospital record using a trigger and a clue to identify of possible adverse event. So basically, they will go through a random sample from the medical record in the hospital by using this sheet to decide whether the patient has suffered from harm or haven't. Once they find a clue or trigger, they will do further investigation and review for the case to see if there is actual harm and what is the cause of this harm. Ideally, it's used by a group of physicians, led by physician, recommended to have 2 nurses with him. The point is why it's not widely used in the kingdom, because it's need a dedicated staff to do this task. So they don't have other job than reviewing the case. Also, some hospital doesn't have the mature system that can help in reviewing the case. Some hospital might still having the paper-based record. So it's hard to review the case, see the handwriting, if you would like to go through the sheet, it's really hard to implement them. But in a study by Klassen and his colleague, I believe in 2010, they do a retrospective data taking from different hospitals. They review around 500,000 medical records from various hospitals. They realized their aim was to compare between the global trigger tools and the PSI, the HRQ, PSI, patient safety indicator, and the incident reporting. They find that sensitivity is different. So the sensitivity of the global trigger tool to detect a harm reached to the patient during the review of patient harm was around 90 to 95. While in the use of PSI, the PSI only detect the harm that reached to the patient by 5 to 10 or 9%, while incident reporting, which is built to be used to report any harm cases, they only detect 1% of these harm that has reached to the patient. So it's recommended to be used so we can monitor the harm that, or the possible harm that could to reach to our patient, but it needs a lot of resources and training as well. We mentioned earlier the value of the patient safety culture, and briefly, patient safety culture can be measured by a survey on how healthcare providers received patient safety culture and the organization. And one of the well-known tool and valid tool is the AHRQ hospital survey on patient safety culture version 2. So basically, it's a survey item. It's divided into 10 domains. You ask the healthcare worker about how they see or perceive the safety culture within the organization that they work for. The domain, it's about teamwork, communication, about error, reporting of a patient safety event, organizational learning, continuous improvement, hospital management support for patient safety, support of clinical leaders to patient safety, communication openness, handoff and information exchange, response to error, staffing and work pace. Before we finish our webinar, the Health Foundation has developed a framework for measuring and monitoring safety. Basically, is they're trying to change the thinking of safety. Instead of focusing on the absence of harm, we focus on the presence of safety. So they have 5 dimensions of safety measurement and monitoring. The first is the best harm, which what we are doing right now actually by having a measure, getting this information and turning them on to information into action. Reliability is to assess how is reliable our system, and by reviewing the process to test them, being proactive, also sensitivity to operation. That means we should have our own formal and informal way to be sensitive to the operation. By, for example, doing leadership walk-around or tracer methodology. That's a good example to be sensitive about the safety of our operation. Anticipation and preparedness, it's focused on being proactive, not react to patient harm. Instead of measuring or reviewing the incident report, whenever there is harm to the patient, we should react. We should start to measure and monitor the safety before the incident and the harm reach to our patient. Again, try to disseminate the information related to safety and patient safety in general, which will help your staff within the organization or with my other organization. I'd like to finish with a global principle from the IHI for safety measurement. The first principle is the purpose of measurement is to collect and disseminate knowledge that improve and that result in action and improvement. The second principle is effective measurement require the full involvement of patient and family and community. We all do a patient satisfaction survey, patient experience survey, but there is a lot of tools that use to take the patient opinion or measurement on how safe is our system. An example of that is that tool developed, I think, by NHS. It's called BMOS30, which is patient measure of safety. It's a survey item similar to the patient safety culture, but it's not about the culture. But you ask the patient about how they perceive the safety within the organization that they admit into it. So the third principle is select, measure, must illuminate an integrated view of the health system across continuum care and the entire healthcare journey. starting from the admission until you get discharged. What kind of care that we provide to them? We should focus on measuring the safety during this process. The fourth principle is data should be collected and analyzed in real time to proactively identify and prevent harm to our patient. Measurement system and evidence and practice must continuously evolve and adaptive. A good example of this is the patient safety culture survey. Now we're having the version 2. Before 2019, we have version 1. So the HRQ work in improving the measurement system for the patient safety culture survey. The sixth principle is the burden of data collection and analysis should be significantly reduced. Clinicians, they exist in healthcare to provide care mainly, but they should cooperate and collaborate in the improvement of patient safety and quality. However, we should not add more burden by data collection and analysis for the purpose of improvement. Try to keep the measurement and the data collection sufficiently simple to be easier to them to collect it and help you in the patient safety improvement. The final one is stakeholder must intentionally foster a culture that is safe and just to fully optimize the value of measurement. And now I have reached to the end of this webinar. It's time, Dr. Vedder, I think, to question.
Okay, thank you, Mr. Faisal, for this rich and informative presentation. I think the most important message that we can get from this presentation is that if you are collecting data and you're not getting any informative, you do not translate it into useful information, it is as useless as not having data. So for the time being, if you may, we will now take some of the questions. A kind reminder that you can ask your questions in the QA section. The first question is that, Mr. Faisal, let's say if there is an institution that wants to develop their own patient safety indicator, and they cannot use the AHRQ patient safety indicators for some reason. What are the numbers they need to get, or the numbers that they will calculate to get their a result, a useful result to improve their care? Let's take, for example, pressure ulcer. How can we calculate it?
You mean what is the right formula to measure, for example, the pressure ulcer?
Yes.
Okay. Speaking about the patient safety indicator from the HRQ, actually it's open resource, so you can find the formula, the numerator, the denominator, and as well as other kind of well-known organization in the field. They might have some open resource which might help you in developing the formula, or to think about what you want to measure actually. For example, for the pressure ulcer, for example, you might to measure how much pressure ulcer cases we have, for example, stage 2 and above, out of the total patient that has discharged from our hospital. So from my statement, you can get a formula. So the numerator should be the pressure ulcer cases out of the total population, which is the patient that discharged from the hospital.
Okay, so another question, Mr. Faisal. How can we decide about the correct sample size in large population? Is it 10 or 20% of the population?
There is no right number for our percentage for the sampling. There is various tools or various type of sampling, stratified, random, convenience, quota sampling. All these is technique and different technique in sampling. However, speaking about the percentage, you might go back to some school or literature, evidence-based. For example, JCI, they have their sampling guide. They can tell you based on the population that you are having, you can decide on the percentage. For example, from 1 to 8 or 70 something, you should include the whole population. You should not get a sample. Above 80, I think, to 300 something, you should take 20%. From 300 to I believe 1,500, you should take 50%. So they give you a guide based on the population. You should decide your percentage. But usually, if you have very low population, you should not take sample. It will be easy to you to collect data. The point from sampling is to make the data collection process is easier. So based on the population that you have, you should decide and justify the right percentage that you choose. Again, it's easier to adopt one of the guidelines that provided by the agencies such as Joint Commission, AHRQ, or others.
Okay, thank you so much. So regarding the incident reporting, patient safety indicators, the differences that they have. So the incident reporting system, as you said, has a low response rate, and for that has low data, right? So can you give me the differences between the three reporting systems again?
Well, I mentioned one of the study, I think by Klassen and his colleague, when he reviewed 500,000 medical record to try to see the patient harm or to detect the patient harm by using the three tools, the BSI from AHRQ, the IHI global trigger, and the trigger that we have built in our incident reporting system. So this incident is considered a reportable incident. So the sensitivity of this tool is varied. So the global trigger actually, it detects 95 to 90, I think, of harm that exists on these 500,000 medical record. However, the incident reporting system only detects 1% of the harm that exists in the medical file, which means that global trigger, if used probably, that will result in proactive detection of patient harm.
But they will require much more effort and dedicated team, right?
Yes.
Okay. So one last question: do incident reports affect the staff performance, or it is just for reducing the risk of mistakes?
Again, it's reduce the staff performance. You mean they will take them away from what they're supposed to do, or in terms of performance and patient safety?
This is it's not clear. This is a question by
I will answer in both ways. Okay. Incident report, it's meant to be learning and reporting system. So when you report an incident, you aim to investigate, to reach to the root cause analysis, to try to tackle the problem of this incident, try to learn from it and disseminate information, and put action plan to assure the prevention of reoccurrence. This is the main aim of incident reporting. However, we can get information about our performance based on the incident reporting system. But incident reporting system is not a very reliable source, I would say, for judging on the performance, because it relies on the reporting culture in the organization. Sometimes you have a harm that reached to your patient, but it's not reported because of the culture. It's not supporting the reporting. So if you are just measuring the performance related to the harm or patient safety from the angle of incident reporting, I think this is not a reliable measurement tool.
Thank you so much, Mr. Faisal, for your prompt answers. So as we reach the end of our webinar, on behalf of the Saudi Patient Safety Center, I would like to thank our speaker, Mr. Faisal, for this great presentation. As a part of the Saudi Patient Safety Center efforts to provide you with timely topics and interesting speakers, we would like you to participate and fill out the evaluation survey, which you will receive by the email. I would like at the end to thank you all for joining us. Hope you learned and hope you enjoyed it. Have a nice evening, and Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you, Dr.